Now, we didn't think about that. We didn't even think about that, but those are things you kind of learn. So, stages of change. Each area has certain treatment goals, okay? And these are very general, and you can get a little bit more. But in pre-contemplation, the most important thing is to establish rapport and to build trust. Okay, get the person to buy into that. You know, you're there to help. You're not going to tell them don't use drugs, or you're going to lecture them. And raise doubts or concerns. That's tricky without lecturing, but it can be done. Contemplation is normalize ambivalence. It's normal for you not to be wanting to quit this stuff that provides a lot of pleasure or makes you feel good about yourself. Pros and cons. Weigh the pros and cons. What does this give you? What does this not give you? When you're in the preparation, clarify goals and strategies for change. What are you going to do? Make the goals obviously smaller and doable, and offer options for change or treatment. Like what? Not every treatment fits everybody. I'm harm reduction, but if somebody wants AA, I have no problem sending them to AA. I mean, for my philosophy is whatever works. But AA is not for everyone, especially if you are bipolar or schizophrenic. It tends to cause a lot more. It tends to kind of mess them up because of the structure. Not even the structure. It's just the kind of the top-down approach. Is like you got to do this, 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 and this. Okay, some people don't deal with that. Some people can't deal with that. So you try to fit the treatment with the person. And you try to go, low level, higher level to obviously treatment centers. Actions. This is where you engage the client in treatment, reinforce the importance of remaining in recovery. This is where you start dealing at the underlying issues of the drug use. This is where, if it's trauma, if it's abuse, if it's family history, if it's guilt, whatever, this is where you start dealing with it. If you start dealing with it here and here, what do you think happens?
I'm imagining that you're kind of just hammering each wall, right?
Yeah, well, I think, sure. Trauma, thinking about bad events causes what?
Would activate them.
Yeah, exactly, causes stress. And the default option for any addict to deal with stress is medicate, okay? So you want to get them stable first, then you start dealing with that stuff. Okay? Then your maintenance. Help identify drug-free sources of pleasure, support lifestyle changes. And these can change. And this sometimes may mean having to dump a girlfriend or a boyfriend or something like that. As I tell all of my clients, you're only as strong as your weakest link when there's two addicts together. And your weakest link may be you, or you the next day. So, it's always kind of a problematic in that case. Now, we're almost coming in here, but cognitive behavioral therapy works really well with addictions. Okay, so does DBT, dialectical behavioral therapy, works very well too. I mean, everybody's different. I mean, I find that cognitive behavioral therapy works with youth better simply because a lot of them aren't really sure what they're feeling or how to identify their feelings, but they're really sure about what they're thinking. And aside from that, you can always kind of project. It's like, what do you think somebody else might be thinking about this? Like, how do you think somebody else might have dealt with that? It's a little bit easier to kind of activate. Now, one of the addict's core beliefs is that life would be unlivable without the drug. Without the drug, I cannot function. Okay? And up to a certain point, they're right. That's why you kind of slowly work them along. So their thinking is that drug use must continue at all costs. And their belief is maintained by cognitive distortions. I'm worthless, or I've let everybody down, or everybody must love me and my group of friends loves me because I'm a great drunk. But what this does, it helps insulate from the pain their use causes themselves and others. So it's almost, in a way, it's these thoughts activate their core beliefs, and it maintains their use simply because it avoids having them look at what's going on. Now, you get somebody, CBT is one, like I said, is one of the ways that I typically use, and there's different techniques you can use, like pros and cons, or diaries, or any kind of technique really works, but make it obviously fit the person that you want, right? I don't typically, I ask people, and sometimes surprising me, but like guys typically don't like journaling. 16-year-old boys don't typically like journaling, but I ask, do you like writing? No, I hate writing. Well, I'm not going to say, okay, great. I want you to write every day what you're feeling. Okay? That doesn't work. You work where you go where it works for them. Right? Some people like songs, like music. Use music. How does this song describe how you feel? Bring a song. You know, you're a musician. Bring some songs you've written. You're a poet. Bring some poetry. What have you. So our system of care is fairly. I mean, it's fairly good. Not great, and very limited, obviously, with any system. The biggest problem with our system of care is that it's not long enough, especially when it comes to adults. Plus, there's that 19-year-old dead zone, as I call it, because you're no longer an adolescent. Typically, you can't go in an adolescent treatment center, whereas by government standards, you're considered an adolescent until 24, in terms of treatment. But it's not always advisable to be putting you in with a bunch of adults that are 50 or 60 years old. So it's kind of like that weird kind of gray area. There's nothing specific for them. But just to look here, we have community support groups, tend to be free, so AA, NA. They could be for like people that are dealing with addictions, that are substance affected. There's detox. Detox, and this is what people typically think of as treatment. Detox is not treatment. Detox is simply a place that you can go to and they help you clean up from the drug. There's doctors there. They typically give you Valium to calm you down, help you sleep, and you're out of there in a week to 10 days. Okay? But that is the dependence part that you've dealt with. You haven't dealt with the addiction part. That's where therapy comes in. Okay? Now you can do detox at home, most people do, or residential. And typically what it is this is self-referred. You phone the detox, you give them your number, you keep on calling every day. And you hope that there's and you have to go like that. Opening now. Now, given that most people don't want to go through excruciating pain, there's always openings. Okay? So, education series, learning about addiction, learning from reputable sources. The province is not a reputable source. Every time I read an expose on drugs, I know on Monday I'm going to get parents freaked out that their kids are addicted to crystal meth. No, that's hay fever. Yeah, but it said in the paper. No, it's not. So, reputable sources, typically universities, American and Canadian universities, European universities, some American government sites, not all American government sites. Be selective. I mean, you guys know how to do research. I mean, I'm kind of speaking to the converted. Recovery houses are actually long-term places where people live in a home with maybe 5 or 6 other recovering addicts, and they have dinner, they have lunch, they sleep, everything. They tend to be 12-step, which technically they're not supposed to be. We don't, to be a licensed program in British Columbia, you aren't allowed to espouse 12-step. You're supposed to be the harm reduction model, but 12-step is used. Right. So, I mean, you know, whatever works, I guess. Addiction counseling services or direct services, which is what I work for, British Substance Use Services, which means that we are directly government. There's indirect services, which are the services in communities that are non-profits. Okay, and they provide very good services at different ages. Our services provide from 13 to like 80. So we have youth worker. I'm a youth/adult. I do both, but typically I'll do the youth. We have outreach workers, which, by the way, came out of because of all that thing in the province about crystal meth. 3 years after the fact, but we got crystal meth workers. So they're outreach workers, and then we have over 65 people that are dealing with people with addictions over 65, which brings its own set of complications, not the least of which is dementia. Right? There's, like I said, outreach counseling. You have high-risk youth. You go out on the streets, homeless. Residential treatment is kind of depending on where you go, but might be the gold standard. The only problem is that it's never long enough. It's only about 3 months up to a month. Typically, should be minimum a year. There is a program in Karamias for youth that they can stay there for a year, but it's not. There's no real like certified therapist there per se. It's almost peer guided, and people that are adults that have an interest in addiction. So that's not necessarily the best thing. And then there's day programs where you can go. It's called DEWE, with day, evening, weekend youth, or day, evening, weekend, where you go and you go during the day. You do exercise, you do group, and then you come back the next day. And so it goes around your schooling and your work. And then there's day talks, which is kind of a similar situation like that. It's not really a detox, but it's a day program for adults. That's it.
Wow.
sorry I rushed you that, but and like I said, if there is, I mean, you know, this is a kind of standing invitation. If there's anything specific that you guys want in the future of one area, like maybe just specifically dealing with therapy, the kind of things you can do with cognitive behavioral therapy, feel free to call me or whatever, what have you. Any questions?
Yeah, well, I have a question.
Go ahead.
Harm reduction.
Yes.
With drugs like heroin. Some of the clients are actually stay on harm reduction regimes for months or years after they work, and they.
Yep.
And
Yep.
what's the argument for not slowly titrating them down to being off the?
You know what? There is that's actually the goal of harm reduction. Like ultimately, that's the goal of to completely. Like so, with a heroin addict, typically if they want to titrate off, they usually either go on methadone, which is a synthetic heroin, which stops people from going into withdrawal but doesn't give them a high, or there's a new form of drug. It's called Suboxone, which was common in the States, which is a lot more effective. It actually gets rid of the urges too.
What's the long length of time? That
they can go from like a month to years and years and years and years, like just functioning on methadone in terms of just.
Well, what would be the motivation for continuing on methadone for years when they're stabilized and work and so on, just completely come off it?
They're typically, you don't get people that are methadone like that are stabilized that well.
Okay.
They're not that stable. There's the issues of mental health issues involved in that.
So if they're functioning well on methadone, would they then be classified as having a dependence or an addiction?
Dependence, because you can go through withdrawal on.
But they may not show the symptoms of addiction if it's not interfering with their life.
Exactly. That's They would have a dependence because the withdrawal from methadone is actually worse than the withdrawal from heroin.
Yeah.
And some argue that methadone may be worse than heroin, right? So there's that argument. But typically, the point is that when somebody goes on methadone, it's not meant to go for a long period of time. It's meant to make you avoid withdrawal. And so you slowly, like let's say they'll give you like 50 milligrams to 60 to 40. And for those of you that don't know methadone, it's just basically go to a drugstore. It's a powdered form. They give it to you in a juice, and you drink it, and it blocks your opioid receptor, so you don't have the cravings for heroin, and you stop having the withdrawal symptoms. After a certain point of time, if you're trustworthy enough, they give you carry-home privileges, which is a year. You can have it at home and do it yourself, and then people can function a little bit better. But the problem with methadone is that it does make you very tired and lethargic. So the only real motivation for not doing it is fear on the part of the person that they're going to go back to heroin.
Yeah, that's right. Okay, that makes sense.
Well, we can probably continue our conversation. You also have brought your business cards.
Yeah.
So in case you...
If anybody wants it, if you have any questions.
Dialogue, you're also
you're more than welcome to give me a shout.
I want to thank you, Talino, for sharing your very, very rich knowledge, experience, and insights. So again, a round of big hands again. I learned a lot from this relatively short lecture. I realized that you probably need a whole day or weekend workshop to learn much more, but this was really
This touches the surface, and like I said, it's good that you get kind of a general idea of what's out there.
I think what I learned is this multidimensional aspect of this addiction. We talked about psychological, physical, socio-ecological, economic, cultural, and probably developmental.
Sure.
Possibly, one of the things that we probably do not have time to talk about or listen to is the spiritual side.
Yes.
When you work with individuals who come from the very spiritually, very rich tradition or background, that would probably be important.
Yeah, very much so. Very much so. And it's you're right. It's like it's targeting the client. I mean, if the problem that they're having is a spiritual problem, you target that. That's your door in. That's your way in. Right. So yeah, for sure.